Hi, I welcome you all to my session today. I, Dr. Betsy Matthew, Consultant Pediatric Intensivist at Gigi Hospital, Trivandrum. COVID-19 infection, the much talked on infection worldwide, and has brought us to a complete lockdown today. Is it just another viral infection? Can we consider it so? It has evolved from an epidemic to a pandemic this March 2020. Today, I will be talking on pediatric COVID-19 infection and its airway support, mainly high-frequency nasal oxygen therapy. The epidemic, which is ongoing and has evolved into a pandemic, of which the ultimate scope is not even known to any one of us. It is interestingly amazing that the pediatric COVID-19 infective cases are so different from that of the adult population. So let's see why these differences occur. There may be a variety of differences between the exposure and the host factors among the pediatric population. As we all know, the children are well taken care of at home and are less likely to get exposed to pathogens and other sick patients. It is evidence proved that angiotensin converting enzyme 2 receptor, that is ACE2 receptor, is the main pathophysiology behind the COVID-19 infection. This particular receptor is less mature and has a less functional capacity in the pediatric age group, and that explains why the pediatric COVID-19 infective cases are less severe than the adult population. We are also aware that these children are more susceptible to respiratory tract infections, especially during the winter season, and as a result of which they have a more load of antibodies against various viruses than the adult population. Furthermore, the children's immune system may be more stronger and is in a developing stage which may respond to different pathogens in a different manner. There have been several case series reported from China with regards to COVID-19 pediatric population. The largest of these includes 2,143 Chinese patients, of which 65% were suspected cases and 34% to be lab confirmed. This study showed that more than 90% were asymptomatic children, including the mild and moderate variety. This study has helped to arrive at a median age for infectivity, finding to be around 7 years of age, with a male predominance attributing to 56% of the infected children and a female dominance of 43%. The median time to diagnose the illness from the onset of illness was found to be around 2 days. And the proportion of severe and critical cases were found to be in different age groups, starting with less than 1 year to be the highest of 10.3%, 1 to 5 years to be 7.3%, 6 to 10 years age category showed 4.3%, 11 to 15 years was found to be 4%, and the more than 15 years of age was found to be only 3%. This statistic showed that young children, especially the infant age group, was more susceptible to the COVID-19 infection. Another case series of Chinese population, including 34 children, had shown us that the predominance of respiratory symptoms attributing to 65% in them, and 26% of mild variety, 9% asymptomatic variety, and interestingly, none of them had any underlying disease. It was interestingly found that more than 80% of the infected children had one family member also affected among them. The most reassuring factor was that all the children recovered quickly and only few radiological changes persisted in them from months together. So now let's go for the categorization of a COVID-19 child or an infant into a suspect and a confirmed case. How do we decide that? A suspect COVID-19 child will be 1. All symptomatic child who has had a history of international travel in the last 14 days, or 2. All hospitalized children with severe acute respiratory illness such as fever, cough, or shortness of breath, or 3. It may be a symptomatic direct contact with high-risk contacts of a confirmed case. So either of these three may be categorized for a suspect COVID-19 pediatric case. Now, how do we confirm, or how do we know that this is a confirmed COVID-19 case? A person or a child or an infant with a lab confirmation of a COVID-19 infection, irrespective of their signs and symptoms, is known as a confirmed COVID-19 case. So this has brought us to an idea about how do we go for categorization of a COVID-19 child into a suspect in the lab confirmed case. How do we go for the symptomatology of these kind of cases? Now, how do we decide about whether this particular child requires hospitalization, or rather, what are the indications for hospital admission? Firstly, respiratory distress, as it is much talked on. Secondly, a room air SpO2, or a room air saturation value of less than 92%. Shock or poor peripheral perfusion, not feeding well or poor oral intake, seizures, and lastly, lethargy. This is just a general guidance to enable us to guide for the hospital admission. But the final decision to admit is at the discretion of the concerned pediatrician or the concerned intensivist. And with regards to children with any underlying disorder such as immunosuppression, immunocompromised conditions, congenital heart disease, or those with organ dysfunctions, will be having a lower threshold level for deciding the admission criteria to the hospital. So how do we go on the testing aspects of a suspect case of COVID-19 infection? The most important sample that is taken for the testing purpose will be a respiratory sample. What are the respiratory samples that is taken into account? It may be a nasopharyngeal swab, a posterior pharyngeal swab, endotracheal tube aspirate, bronchoalveolar lavage. Either of these, one of these may be taken depending on the case or situation may be. What is the investigation that is done for this particular sample? A reverse transcriptase PCR study for COVID-19 infection is carried out. What are the other investigations that may be done to find out this COVID-19 apart from the respiratory sample analysis? There may be a complete blood count analysis which reveals a lymphopenia. There may be a chest X-ray that is carried out which shows a wide variety of changes, and serum chemistry studies in those to rule out organ dysfunction or to assess the severity, and lastly, arterial blood gas analysis, especially in those children who are mechanically ventilated. So, how do we go about the treatment of a suspected or a lab-confirmed COVID-19 pediatric case? As I have mentioned earlier, the largest case series reported from China of 2,143 patients showed that more than 90% were asymptomatic or the mild variety of the infection, and only 10% required hospitalization either in the wards or the pediatric ICU. So this aspect of treatment guidelines is mainly meant for those 10% which may be requiring hospitalization. The second case series which I mentioned of 34 Chinese children showed a predominance of the respiratory symptoms, which means that the main support has to be given for the airway. So I will be dealing with airway support, mainly supportive measures, that is high frequency nasal oxygen therapy. What is high frequency nasal oxygen therapy? It is designed to provide heated, humidified and high flow mixture of both oxygen and air at a higher flow than the patient's inspiratory flow. Why do we need to give heated air? Because it helps to reduce the resistance in the nasal mucosa which may be induced by cold air. Why is it humidified? It helps in a better mucociliary clearance, and also it helps to reduce the uncomfortability as a result of the respiratory distress. Why do we need to give high flow to the child? Because it helps in a better oxygen delivery to alleviate the issues of hypoxia, and also helps in providing a better gas exchange. So what is the advantage of high frequency nasal oxygen therapy? Respiratory distress may cause a huge respiratory muscle burden which causes a fatigue to the respiratory muscles. As a result of respiratory distress, there may be a huge amount of energy expenditure which may be alleviated with the help of high frequency nasal oxygen therapy. So So, aren't there any side effects for high-frequency nasal oxygen therapy? Yes, there are. That is, pneumothorax, pneumomediastinum, and lastly, the child may go in for an invasive mechanical ventilation. So how do we prevent these side effects of HFNO therapy? The only way out is close and continuous monitoring of any patient on high-frequency nasal oxygen therapy. What are the parameters to be observed for this particular HFNO therapy? Firstly, the consciousness of the child, airway patency, respiratory rate, chest rise, room air saturation, SpO2, the FiO2 level, hemodynamic variables such as the heart rate and the blood pressure. Are there any other indications for HFNO therapy other than the so-called respiratory distress? Yes, viral bronchiolitis, bronchial asthma, and as a bridging mechanism when we extubate a child from invasive mechanical ventilation. How is high-frequency nasal oxygen therapy different for COVID-19 cases compared to the usual pediatric population? As we all know, HFNO may be used to alleviate the hypoxemia related to the COVID-19 cases. It also emphasizes on the use of airborne precautions for all the staff dealing with such a case. Risk of airborne transmission to all the staff concerned with such a case is low so long as well-fitted HFNO system, proper personal protective equipment along with strict airborne precautions are executed. Can HFNO be used in any room facility? Well, several arguments are being stated that HFNO may be used in regular rooms without negative pressure, and some state that it has to be used only in negative pressure rooms. Basically, it has been divided into two rooms, class N, that is those with negative pressure rooms, and class S, those rooms without negative pressure. It is recommended that HFNO therapy to be used in negative pressure rooms with separate area for the donning and doffing of PPE. But however, HFNO therapy may be used in a room without negative pressure, but with all strict airborne precautions to be taken care of. Before I conclude this session, let me add on about the airborne precautions to be followed by all healthcare personnel in hospitals. Firstly, a well-fitted N95 mask, face shield or goggles, impervious gown or a coverall, and lastly, the gloves. I thank you all for listening to my session and hope to meet you soon.